Welcome everybody to the virtual Board of Public Health meeting. I'd like to call it to order and only say maybe 3 or 4 things to start with. First is that as we'll hear from Dr. Drenzik, finally the COVID pandemic is taking a turn to the right way, and a lot of good effort has been used for that. Secondly, now we're all caught up and worried about the actions in Eastern Europe and Ukraine. It's hard to get that out of our minds. Thirdly, on a good note, I was leafing through the most recent Journal of Infectious Disease and Clinical Infectious Disease, and I ran across 2 articles from Georgia, both of which had Sherry Drenzik as an author, and one of which also had Dr. Toomey as an author. So it's pretty unusual to have 2 peer-reviewed journal articles at the same time as the Board of Health meeting, both from the Board of Health. So congratulations to both of you. One was on the seroprevalence of COVID in Georgia last year, and that's with Emory co-investigators. And the other one was investigations in the school district, which was done with CDC. So congratulations to both. And then thankfully, before we call roll, I want to thank again Norman Eubanks from our staff for putting all this together and hopefully making sure it all runs well. So thanks, Norman. Calling the roll, I'm Jim Curran and I'm here. John Haupert.
I'm here.
General Carden.
I'm here, sir.
Dr. Cheek.
I'm here.
Dr. Shin.
Present.
Dr. Cowell's here yet. How about Dr. Valier White? We know Dr. Mercer and Dr. Rodriguez can't get it, and the others can check in when they arrive. And that having been done, I'd like to ask whether the minutes from the past meeting have been read and approved. Does anybody motion that we approve them?
I move approval.
Second. Okay, all in favor? Aye.
Aye.
Aye. Aye.
Dr. Toomey, the floor is yours.
Yeah, thank you so much. What I'm going to do, because we are, as you know, during legislative session, and we have some time constraints of some of our speakers who are expected to be doing 2 presentations at once. I'm going to kind of jump queue and go a little bit out of order and have Megan Andrews go first. There's so much going on in this legislative session, and unusual and unexpected bills being introduced, that we thought it was an important thing to bring this information forward to the board, to make them aware of some of the discussions going on at the Capitol, but also about our agency bills that are looking very favorably as they're moving forward, and including improving our lead program. So why don't I just turn it over to you, Megan, and let you update us on where we are and on our agency bills and some of the other bills that affect public health.
Absolutely. Thank you, Dr. Toomey. Can everyone hear me okay?
Yes.
Okay, great. So you can go to the next slide. We are, as Dr. Toomey mentioned, in the middle of legislative session. Today is legislative session day 25 out of 40 total session days, and crossover day, which is the next big event, is next week on the 15th. That is the day that bills need to cross from one chamber to the next in order to remain alive for the rest of session. So it's a big day, usually late hours, and a lot going on. So we are very busy with committee meetings leading up to that point in time. Sine Die is the last day of session, and it's scheduled for April 4th this year. So that'll be the last day that bills can pass for this session. You can go to the next slide.
Yeah.
I did talk about this a little bit in the last board meeting. We are seeing a very large increase in the number of bills that we are tracking and that have direct impact on public health. Looking at 2020, we're up to 203 bills that we are tracking that have some sort of impact on public health. And 77 of those are considered direct impact bills, which means they're going to require the department to do something different, change our operations, start a new program, transfer a program, et cetera. So when looking at these numbers from 2 years ago, we had 186 bills at the end of legislative session that we were tracking, and 43 were considered direct impact. So we're only on day 25. There's still several days to go of session days for more bills to be dropped. So it is quite a busy year for us based on this information that we're seeing. You can go to the next slide. So I did want to give you all an update on our 4 agency bills that are dropped and are quickly moving through the legislative process. The first is our childhood lead poisoning bill. This would bring Georgia law in line with CDC best practices for at what blood lead levels there should be state intervention for children, for lead poisoned children. That bill passed out of the House last week unanimously. It's being carried by Chairman Dempsey, and the bill number is there in case you want to keep an eye on it, House Bill 1355. Right now, it's been assigned to the Senate Health and Human Services Committee and is awaiting a hearing on that side. Most bills, once they cross over, they kind of wait in committee until after crossover day, and then they start taking up the other chambers bills. So I'm not anticipating any movement on that one until after crossover day. The second one is the EMS wrap-back bill. This would allow our EMS office to participate in what's called the wrap-back program run by the GBI and FBI. And it would allow GBI and FBI to retain fingerprints of our EMS licensees. And if there's a criminal violation that occurs after they're licensed, we would be notified. Currently, they're required to notify us, but sometimes do forget. So this would be an automatic notification to DPH of any sort of criminal penalties of our licensees. So that bill passed out of the Senate. It's been assigned to the House Public Safety and Homeland Security Committee. And again, I'm not anticipating a hearing on that on the House side until after crossover day. The third one is our Smoke-Free Air Act and vaping. The Smoke-Free Air Act passed in 2005. And that was obviously before vaping was popular or really even invented. So this bill would update the Smoke-Free Air Act to prohibit vaping in any locations where traditional tobacco smoking is currently not allowed. So schools, government buildings, daycare centers, things of that nature. That bill passed the House last week as well, and it's been assigned to the Senate Judiciary Committee. We are also not anticipating a hearing on that until after crossover day. And then the last one is Senate Bill 539. It is currently assigned to the Senate Health and Human Services Committee, and that bill is up for a committee hearing in a little less than an hour. So that's why I'm going first, because I have to go testify on that. Senator Bo Hatchett is carrying that bill for us. So there will be a hearing this afternoon and hopefully a vote. So we're hopeful that one will make the crossover day deadline as well. You can go to the next slide. And I did want to just draw your attention to a handful of bills that are on our radar that we're just keeping an eye on. As I mentioned, there were about 77 that were direct impact bills that we're tracking. So this is just a little sampler platter for you. The first one is the Georgia Raw Dairy Act, House Bill 1175. That one passed the House. It would allow for the sale of raw milk for human consumption in Georgia. Raw milk is unpasteurized milk currently it is only sold in the state as pet milk. So that bill did survive crossover day. So we will see what happens on the Senate side. The next one is a Medicaid waiver for HIV patients. It would allow anyone with HIV to qualify for Medicaid. So that bill also passed the House. It would certainly help with our Ryan White services and ensuring these patients have access to care for many conditions, not just their HIV treatment. The next one is dog menus. That's House Bill 1376. It's currently in the House Agriculture Committee, and it's scheduled for a hearing and vote on Wednesday morning, I believe at 8 or 8:30. And what this bill will do would be allow restaurants that have dogs on patios to provide a dog menu. So patrons could order food for their dogs and serve it on the patio, and the dogs could eat with their humans. So that obviously impacts public health because we do restaurant inspections. So we are definitely keeping an eye on that one as well. The next one is House Bill 1443 related to food trucks. This bill is also in the House Agriculture Committee. It's scheduled for a committee hearing this afternoon at 4 o'clock. So we will be there to answer any technical questions for the committee about our current operations. Essentially what this bill would do would allow food trucks that are permitted in one county to waive in to other counties to operate, as opposed to being permitted in every county and wherever they wish to operate. It would be kind of a more streamlined waive-in process as opposed to traditional permitting. The next one is Senate Bill 345, which passed the Senate and survived crossover day. It's a vaccine passport bill. As introduced, it had a fairly broad impact on all vaccinations and prohibiting vaccine passports. The substitute that passed out of the Senate committee and the Senate floor narrowed the scope down to just COVID vaccines. So it prohibits government entities from requiring proof of COVID vaccination for any sort of government services. There is a sunset provision that was added in committee for 1 year. So we are definitely keeping an eye on that one as well. And then the last one I want to talk to you about is maternal autopsies. That's Senate Bill 496. That bill passed the Senate, so that one also survived crossover day. The Maternal Mortality Review Committee that's housed within DPH that reviews maternal deaths has issued recommendations with their reports on maternal deaths in Georgia on how we could improve our outcomes and reduce maternal deaths. And one of those recommendations pretty consistently has been maternal autopsies for women that died of unknown causes. So like a motor vehicle accident would be an exception, but for other causes of death, there would be an autopsy performed in order to help better inform the committee in their review process and hopefully make better recommendations for Georgia to improve maternal outcomes. So that bill did cross over as well. So that's something that we are keeping an eye on because it will definitely impact our review process. And so that is a quick summary of our agency bills, as well as some a little taste of some of the bills that we're tracking. I'm happy to take any questions if there are any.
Andrews, that's terrific. I can see you're keeping really busy. I just had a question about the proposed governor's pay raises for state employees and how that affects public health.
Yeah, thank you for bringing that up. So the governor in his amended budget, as well as his big budget, they call it, that's the general base budget that passes every year, recommended $5,000 pay raises for all state employees as a cost of living adjustment. In the amended budget that passed out of the House, and it actually passed out of the Senate earlier this week. Maybe it was last week. All my days are running together now, but it did pass both chambers. So we are seeing that coming down in the amended budget. And I know our finance team is working on how that's going to roll out to our state office as well as our districts. As far as the big budget, the governor also recommended that in our big budget. The House is putting out their version of the big budget on Thursday morning. So we are definitely keeping an eye on that to make sure that will be kept into our reoccurring base budget.
Could I
And
say
pu- and
something?
public health will be included.
Yes, yes,
Yeah,
and all of our county boards of health.
That's just what I was going to add, Megan, is that this includes not just state employees or the district employees, but also the county board of health employees. So it really is an extraordinarily positive thing for public health, as well as other state agencies.
Congratulations on that. That's something that's been needed for a long time, and it's really terrific. Any other
Yeah.
questions for Ms. Andrews? I guess you can go to your non-lobbying job.
I appreciate that, y'all. Thank you so much for your time.
Kathleen, back to you.
Well, actually, I'm going to turn it over to Dr. Drensick, who has some good news for a change about our COVID numbers. And I think what I'd like to do to set her up is to talk about what she sees the future holding for us in Georgia, as well as some of the news from CDC yesterday modifying how we're going to be reporting, because I think you're going to be seeing some changes in just how COVID is reported by states and localities.
Okay, thanks, Dr. Toomey, and thanks, Dean Curran, and great to be here with you, members of the board. As usual, I would like to give my brief snapshot of the COVID-19 epidemic in Georgia. And as Dr. Toomey alluded to, we do have some good news this time with my usual touch of caution, right? What's going on now with COVID-19 in Georgia? So first of all, the Omicron variant surge that we encountered that began in early December and peaked at record high levels in mid-January has now retreated. We really don't know when the next variant or if the next variant will emerge and surge, but I have a feeling that we may indeed encounter surges in the future. So we look at what's going on now here in Georgia and also nationally. When we look at all of our main surveillance indicators, cases, hospitalizations, and outbreaks, first of all, these numbers have really plummeted by more than 60% in the past 2 weeks. So what we've been seeing over the last few weeks here in Georgia is really a very strong retreat of our Omicron surge. All of our surveillance indicators, both cases, hospitalizations, and outbreaks have really plummeted by close to 60% over the last 2 weeks. And our death numbers are now also dropping steadily. We've encountered about a 25 to 30% decline also in the past few weeks. One thing that I wanted to highlight when we were thinking about the Omicron surge, both here in Georgia and also globally, is during the course of the Omicron surge, a sister subvariant to Omicron emerged in some countries called BA.2 or Omicron 2. This particular subvariant essentially was responsible for some surges in many countries, but is really not, at least yet, taking a strong hold here in the US, although it is spreading and it is increasing slightly from week to week. As of last week, this BA2 comprised about 8% of all virus in the US and about 4% here in Georgia. And I noted just before our meeting that CDC updated the numbers again. And again, these numbers have increased a little bit more. about 11% nationally and about 7% here in Georgia. So again, that is significant in the sense that we do have this variant, but it is not really driving any surges. We're still seeing this great plummeting and dropping of cases. And whether this BA2 really becomes the variant responsible for a new surge remains to be seen, but it's moving pretty slowly so far here in the US. We're really concerned about any variant that's spreading simply because, again, when we look at the number of people vaccinated here in Georgia, we have about 55% of our Georgia population that's fully vaccinated and about 22% are boosted. And so in this situation, because of that, and these numbers change, very, very slowly, we still have opportunities. We have individuals that are susceptible, and we have opportunities for variants to, again, emerge, change, and spread. So we want to keep our eye on that. One thing that I wanted to highlight when we were talking about our Omicron wave, and really, again, throughout this entire period, once vaccines became available, is that even though we do see breakthrough infections, meaning people become infected with SARS-CoV-2 Omicron variant, we really are seeing that the severe outcomes as hospitalizations and deaths due to COVID are now, for the vast majority, have been among the unvaccinated. So again, we really do think that the vaccines are critical still, particularly 2 doses plus a booster. And I'll show you that as time goes on. Can I have the next slide, please? So I wanted just really briefly to show you visually our 3 main surveillance indicators as we did last month, and show you a little bit, again, how different they are as well. So if we look at our case numbers, this is total cases, both PCR and antigen cases. This is the entire pandemic. And again, when we start looking at these case numbers here on the far right, we really have plummeted, greater than 90% from our January peak of Omicron. So we're really down to, under 1,000 cases a day. As of today, we had about 900 cases. This is from, our peak of 27,000 daily cases. So again, in this 2-month period, we had a very rapid ascent, a very rapid descent. And only now really are we really kind of below where we were, sort of in the summer of 21. And we're really, essentially where we were when we very much first started out in the pandemic, all the way back in 2020, in the beginning of 2020. Next slide, please. So that was our case numbers. Here are our hospitalization, visualizations as well, which are also plummeting. So when we're thinking about our Omicron wave, which is again in the first graph at the far right, we had about an 80% decline in our daily census of individuals that are hospitalized with COVID from our January peak. And also about, again, an 82 or 83% decline from our Delta wave from that peak, which was again in the summer, August, September peak as well, probably early September there. So again, our hospitalization numbers are dropping. Our burden on our healthcare partners is again receding somewhat. And one thing to really note, which was different about Omicron versus Delta, is that if you look at the graph on the right, when we think about individuals hospitalized with COVID compared to the Delta wave before it, the ventilator usage during the Omicron wave was decreased by greater than 50% than during Delta. You can see a strong difference there. So again, indicative of the severity of these infections, even though again, individuals may have been hospitalized. Again, our ICU usage and our ventilator usage was much decreased versus during the Delta wave. Next slide, please. Here's our next indicator, which are deaths. And so deaths, again, as we've mentioned several times, throughout these months, really are a lagging indicator. So then as you look at the shape of these, this graph, it looks similar. We have the various waves. But again, if you sort of look at, we're really just starting to come down now. And although, again, these death numbers here, again, during Omicron are the vast majority individuals that are unvaccinated. And as you can see, we really, again, have lower number of deaths than we had during our Delta wave. But again, and I think tragically, because they, in many cases, are preventable, really are persistently higher than we really, than really indeed perhaps they should be. But again, they are beginning to decline, and that is good news as well. Next slide, please. This one I like to show you because in this one, we are going to put the 3 surveillance indicators together, together on one graph, and you can sort of see the magnitude. So we're going to compare our Omicron wave. The red bars are case numbers, the blue lines are hospitalization, and the green line are deaths. So again, as we look at this Omicron wave, we see what is called this tremendous decoupling of case numbers versus the severe outcomes, meaning the case numbers are huge compared even to the number of hospitalizations and deaths. And if you look at the Delta wave before it, you really see less decoupling, meaning the case numbers are much less, but as a proportion of the number of cases, the deaths and hospitalizations are quite a bit higher, indicative of a more severe virus than Q. So again, all of this, just kind of really highlights everything that we just showed, and also highlights now, again, this tremendous decline in all 3 indicators as of this week. Next slide, please. Last but not least, as I mentioned earlier, when we're thinking about the impact of vaccination on our surveillance indicators, I think this graph really highlights and underscores it very, very well. We're going to look at really on this slide, the 3 main surveillance indicators. Cases are up here on the upper right, hospitalizations are the lower left, deaths are the lower right. So if you look at these graphs, and really, it's really just a, kind of visually impactful right from the beginning. If you look at the black lines represent individuals that are unvaccinated. The red lines are those with 2 doses of vaccine. The gray lines represent a booster dose as well. So as you can see, the impact of the booster dose at those blue arrows is tremendous in really lowering the risk of again, not only infection on the upper right, but clearly and very, very importantly and strongly, hospitalizations and deaths. And as you can see, really, I think another thing that's quite evident here, if you look on the lower right, the death graph, look at how much, sort of lower, even among the unvaccinated, the death numbers are versus during Delta. So again, these are still represent, kind of these preventable deaths and preventable opportunities. But all in all, we really are seeing, a big difference when it came to the number of deaths due to Delta versus Omicron. But again, that booster dose is tremendously important in reducing that risk. And unfortunately, again, in some ways, when you look at the upper left, this is our percent of fully vaccinated individuals in Georgia. And again, it really has stayed the same, for many, many, many months. And again, as we're thinking about how much we could still make a difference in lowering these deaths and hospitalizations even further, all above this line, we really have some opportunity for susceptibility and for emergence of variants. So next slide, please. So when we're thinking about indicators and risk indicators, we really are pivoting quite a bit. As Dr. Toomey alluded to in the beginning, we're really thinking as a nation of other ways of, since we are experiencing again a retreat in this Omicron variant, and thinking about what the future holds for assessing risk, data to again be able to identify and display risk. CDC very recently, as of last week, actually released some new guidance about how to assess risk of COVID transmission, now in our current landscape versus before. And again, it's highlighted essentially predicated on 3 metrics. And one is what we call a leading metric, case numbers, but it also is heavily weighted on, again, severe outcomes. So again, it really is, again, a way to try to prepare and plan, not only for an individual, but for communities to prepare for a healthcare burden. And so it really has this dual purpose: individual, sort of decisions about mitigation and mask wearing, and also community decisions about planning for hospitalizations and capacity. So these 3 metrics are new cases, essentially case rates in the last 7 days per county, new hospitalizations on a regional level in the last 7 days. Some counties don't even have hospitals, so they use a regional hospital data, and then a percent of inpatient beds occupied by COVID patients. So CDC essentially, sort of morphs these 3 metrics together and assigns a county either a high, medium, or low, essentially a orange, green, or yellow designation, really to show kind of what the transmission level is in a given county right now. So this is Georgia as of this week. And again, according to these metrics, we only have 22 counties now in Georgia that are considered to have high COVID transmission. And that's down from these same metrics a week ago when they first came out. That was down from 68 last week. So it really, again, highlights this decline that we're seeing in our surveillance indicators. But again, it also, when you think about looking at risk in this way, again, we're thinking about, it used to be that CDC metrics included both case rates and also PCR percent positivity. That's how we used to, designate counties as high transmission or medium or low. When we're looking at risk of COVID transmission locally, again, now, again, it's really important not only to look at, sort of new case numbers, but also impact on the healthcare system. And we're going to rely less upon PCR percent positivity. There's so many home tests out there now, and we and CDC both don't receive all of those results. It's really difficult to sort of use PCR percent positivity as an accurate depictor of risk. And this is, again, all part of our overall, sort of surveillance pivot over time, where we're going to sort of look at, as a whole, broader surveillance strategies rather than necessarily the sort of individual every single day numbers as an assessment of risk. That we really have to look more broadly, that we have surveillance systems in place, that we are able to, again, be able to track where and when where the virus is. Again, who is it impacting? Are there variants that emerge? And are there, sort of long-term effects? But kind of every single day numbers are less important, and we look at this broader risk indicator. So next slide, please.
Sherry, I have a question on this slide before you go.
Sure.
So I know all 3 measures are included in the red, yellow, orange. I mean, the green, yellow, orange thing. Are they a weighted average of the 3, or, each one counts a third? How do you add these up to get to a color?
Yes, and the CDC website does a nice job of doing this. But yes, there is a degree of weighting, and then there's some modeling involved in as well. So they take together these regional data, and yes, again, there are a way to combine these into essentially a risk score. So that's how CDC does that. And I think that what makes it, and the risk score has to do with like kind of whether it's greater than this amount and less than this. And again, it allows both an individual and a county to be able to look at the metrics and decide, sort of at the community level, what are appropriate mitigation strategies, and at the individual level, what are some decisions that can be made.
I guess what I'm asking you is to get inside the model. I mean, if you have high cases and low hospitalizations and low deaths, where does that put you, or vice versa? All three of them have to be low, or how?
Yes, the cutoff point, if you see it, the cutoff point essentially is right for all. When you look at each one individually, there will be a number for a cutoff for each one, and you sort of go along with that. So yeah, I think that you're right. And I think that as we think about this model, I think what is most important from my perspective to keep in mind is less essentially what the number itself turns out to be, but realizing that we still need to have some leading indicator. It's a little, if we are only looking at the lagging indicators of hospitalizations, it takes a few weeks to get there. And we want our communities to be able to plan for this capacity, but we want to be able to at least be ahead of it to the point where we can indeed look at case numbers, which are going to be first. So that's how I would describe the need to kind of combine these two together. And if you want further detail about the model, I can find out. I can send you more about how CDC does it, but I think that's the easiest way to explain it. All right, so let's go on. Since we're on a roll and you can hear me now, let me just summarize and essentially, kind of wrap up and then take a quick look into the future. And I've alluded to some of this as well. So here we are. It's clear our Omicron surge has retreated, and is continuing to retreat quickly. Most of our surveillance indicators are plummeting. Our deaths a little slower than the others. This can be characterized as essentially a quiescent phase of the virus, but it is not the same as saying the pandemic is over. By no means is that the case. This virus is still with us. It is still with us, and its track record is strong in the sense that it has proven very adept at changing and evolving and mutating. And it still has plenty of opportunity to do so, both in populations that remain or under vaccinated, and also the number of immune compromised people that are here in Georgia and are here in the US. It is thought that, again, even the Omicron variant may have emerged, and there's a number of case studies sort of showing in an immune compromised person how much this virus can mutate and change over time. So again, it is not over as long as there are susceptible people and as long as there are transmission opportunities. And when we're thinking about the future and we're thinking about planning for, having an infrastructure in place and a surveillance structure in place to be able to monitor this virus, we must keep in mind as well that in any pandemic, there is going to be, sort of a long-lasting footprint. It's not just that, again, at this point, these case numbers have plummeted and that's it. Again, one of the things that concern me a lot is that, there are a lot of individuals that have, sort of long-lasting health effects from their COVID infections. Long COVID may indeed play a role in this longer-term footprint. So no matter what, we cannot say that COVID prevention is not a priority on an individual level and on a community level. So our usual suspects, vaccination and boosters especially, but having appropriate surveillance that allows us to monitor in the way that's appropriate, that really does give us an indicator of risk and give us an indicator of perhaps some of these longer term effects, having testing in place and traditional mitigation strategies when appropriate, thinking about masks when appropriate or masks among immune compromised individuals. This is critical to continue these declines. And I'm going to say when and not if this time, when we face other variants that emerge. and result in surges that we have not yet seen, perhaps even in years to come. So I thank you all for your time. I apologize again for our audio issues. And that's it for me. Thank you.
Thank you, Sherry. Are there any comments or questions for Dr. Grenzik? Well, I have one, Sherry, if no one else does. Maybe it's more of a comment than a question. I'm still quite worried about COVID. Not in the next month or so, but our relatively low vaccination rates and our very low booster rates are supplemented by some probably substantial herd immunity from Omicron infection. And as all of these things wane, our lack of desire to get boosters and our lack of desire to get vaccinated could haunt us 6 to 12 months from now. So I'm just kind of worried about this. I'll just add my worry to your worry.
Me too. I agree with you completely.
Any other comments from Dr. Grenzik? This is good news, and it's really nice documentation of this. And you're doing it while you're running. And congratulations again on 2 scientific articles published this week. You may not have seen them yourself yet.
Thank you, Dr. Curran.
Dr. Toomey, I think we're turning it back to you now.
Yeah, I just had a couple of things I wanted to point out and emphasize. First of all, just once again, we are not through with COVID. We have to continue our work in this virus, and we must continue with vaccinations. We must continue with educating about the importance, and we will continue to work in many communities around the state in using CORE and using our own teams from the health departments. And so just know that we are continuing to work on this, even as we're moving gradually into other areas back to the core aspects of public health. I did want to say before I move into my brief remarks that I am so sorry about this audio. I see Dr. Cheek's face in front of me. This is not the first time that this has happened. This is the second or third time that this has happened, which is why Dr. Curran has been so gracious at being our host. And so it's clearly our equipment here. And I promised you this last time, I further promise you that this, even if we have to buy brand new equipment by next month, we will do so. Again, my sincere apologies, but that does not in any way take away from the important messages that Dr. Drenzik just gave us, because I think it's kind of gotten lost in the chatter in the news that we're over, we're moving on, but we're continuing our COVID work at the community level. Certainly, as you heard from Megan, this session is extraordinarily intense this year, more so for us at the state level than it is for the districts or counties. And so part of that has to do with the pandemic and the response to the pandemic. And some of it is playing catch up because there's so many things didn't get done in the last legislative sessions because of so much energy and attention was directed at pandemic response. So I am thrilled at what we are seeing, both in terms of our budget. Our this year's budget has that salary increase for all of our staff. As we said, not just state and district, but also Board of Health. We'll be hearing on Thursday what the House recommends for the budget for next year. It probably, given the usual timeline, I'll be testifying to the Senate on the House budget next week, and then we'll see what finally comes out of this. But I am fairly certain that we will see that continued salaries increase for state employees, including public health as well as Board of Health employees, which really is welcome and provides about a 10 to 11% increase for many of our epidemiology staff, as well as our environmental health staff, who have been core staff in this response, on the ground staff in the counties, doing the boots on the ground work, and yet have not made the kind of salaries that you would have expected. And so this $5,000 increase raises them about 10 or 11%. And that is, again, very welcome. I also wanted to note that as we're shifting and ramping down some of our COVID work, we are going to continue to keep contact tracers in place, but not at the numbers that we have. We're going to continue to have test sites available, but again, not at the capacities that we had. And we're doing that because we are recognizing that there is a risk for a surge again, perhaps by the fall, perhaps next year, whenever that is. We want to be able to act with more agility, with more speed, with more intensity than we were able to do initially. We didn't have that infrastructure in place. So we don't want to dismantle everything and have to reposition everything again when that comes. So even as we're transitioning, we will keep in place that COVID infrastructure for our response. But other good things are happening. For example, March 1st, we began doing our home visitations again. And these were some of the programs that were suspended for almost 2 years because of the pandemic. And this is, again, very, very important. I think these services coming to households are just absolutely critical, both for the mothers and for the babies who are receiving these special services. So we are really happy that this work is now starting back up and reaching Georgians all over the state. I wanted to mention again a couple of these bills that Megan noted are agency bills, both on the recognizing vaping, and the Clean Air Act was something we really had wanted to do. If you think the Clean Air Act came into being before vaping was popular, and so we saw this was necessary, and to be able to retroactively, as it were, add this is, I think, a very important opportunity for us to remind everyone about the potential dangers of smoking and vaping, and the lead issues and our ability now to from a high of 15 in a child to down to 3.5, which is what is recommended by CDC as the level at which we can begin our intervention, is really incredibly important. That we are really out of sync with the rest of the country, and certainly with CDC recommendations with our past lead regulations. And so this is a great opportunity for us to improve child health. I wanted to call out as well in the governor's budget that Medicaid for mothers postpartum has proposed to be extended for a full year postpartum. That is something that our maternal mortality working group has recommended really for years. And to see that being proposed in the budget is again, a very, very good news for us. And we're looking forward to that passing and having that year of care for those high-risk moms and mothers throughout the state. The other issue that was raised were the HIV waiver. That's not our bill. That's not an agency bill. Dr. Curran, you know, many of our colleagues had worked on this more than 20 years ago to try to get this HIV waiver in place. And I really salute Sharon Cooper and the individuals working with her to bring this to the floor and have this pass the House, and we hope pass the Senate. The importance of this cannot be understated because we in the South report the highest rates of HIV in the country, and we in Atlanta report the highest rates of HIV of any counties. And rural Georgia has some of the highest rates reported anywhere. And we cannot really end this HIV epidemic in Georgia without having easy, seamless access to care, linkage to care, outreach, testing, linkage to care, and continuation of care. And this is what the HIV waiver will provide, along with, and really working in sync and expanding the potential of our Ryan White programs. Again, this was a dream that we had to be able to put this in place many years ago. And I see this as the one of the real keys to our being able to end the HIV epidemic in Georgia, because treatment is prevention for HIV, coupled with PrEP and other outreach and prevention education. So this is a very exciting development that is going on as well. I also wanted to do a brief shout out to Senator Burke. Senator Burke was the one who has introduced the maternal autopsy bill. As Megan noted, this was something that, again, our maternal mortality review committee has recommended. This will allow us to better understand why our maternal mortality is what it is here in Georgia, and more importantly, how can we focus on those preventive interventions that we can in public health achieve an improvement in those poor outcomes. But these are just some of the things that we're looking at during the legislative session. And I really am very optimistic that we will see some positive outcomes of our budget as well. And I'll be happy to answer any questions.
Congratulations, Kathleen. It's really needed and a lot of good work inside the Capitol. Any questions for Dr. Toomey? Any comments? Dr. Coles has joined us and is so noted for the quorum that we have. So I guess if there are no more questions or no more comments, it's time to say goodbye. And once again, thanks to Norman and thanks to all the folks downtown who are trying to keep this act alive. And especially thanks to the work of the people in the department.